You all for the patience, appreciate it. So this is the VCU Department of Internal Medicine Grand Rounds. Today is June 6th, 2024. Today is a special lecture. This is one of our endowed lectures every year called a Thomas Lecture, hosted by the Division of Allergy and Immunology here in the department. So I'm going to say a couple of words about the Dr. David Thomas, Charles Thomas, excuse me, first, and then I'll introduce our speaker. So this particular lecture is the Thomas Lecture, honors Dr. Charles Thomas and his wife, Evelyn Thomas, for their contributions to the rheumatology field through their generosity. They have endowed 2 faculty positions, 1 fellow position, and research funds that have helped the rheumatology division to achieve its many academic goals. I want to take a couple of moments just to reflect on Charles Thomas. He was born in 1876, so I think it's important to understand the contributions of valuable folks in the last that come before us. He was born in 1876 in Patrick County, which for those of you who are not familiar with is down in Southwest Virginia, south of Roanoke. Floyd, Patrick, and Henry County are all down there. He was a third-generation farmer initially. His family had owned land down there for about 100 years before that. Graduated from MCV Medical School, at the time Medical College of Virginia, in 1903, and returned to do private work down in Patrick County, Henry County, and Floyd County until he retired in 1956 from medical practice. Following that, he passed away in 1964 and donated more than 50% of his estate to MCV, which has supported, at the time, was called the Division of Connective Diseases, through research funds for now over 60 years through his donation. So the work by the Thomas family has continued to support the rheumatology division here in the faculty and fellow position endowments, but it's an important contribution to us. So we appreciate that and acknowledge that. The speaker today is Dr. Santhosh Kumar. He's an associate professor in the Division of Allergy and Immunology with a joint appointment in the Department of Pediatrics and Internal Medicine. His focus is on family-centered care, and he was the first to start a family model of care of allergy and immunology here at VCU. He's been recognized by his peers for his clinical care by awarding the Richmond Top Doc for several years. He's also well known in Central Virginia for his expertise in eosinophilic esophagitis. In addition to his clinical work and teaching, Dr. Kumar is a physician informaticist and serves as a liaison between the information technology and clinical side of the healthcare system. Dr. Kumar has led and participated in several clinical trials, has published manuscripts and abstracts, and has presented in national and international conferences. He's involved in several national committees and is a member of several national organizations. Please help me and invite Dr. Kumar up here to hear his lecture.
I want to thank the organizing committee for inviting me, and I'm also very honored to be speaking at the Thomas Lecture. So the topic I chose today, I think is very relevant to what we do in the field of medicine, with a focus on electronic health records, that is EHR. So my disclosure is that I'm a member of the EHR subcommittee. It's a national committee for the Adverse Drug Reaction, Biologics, and Latex Committee. This subcommittee is looking at EHR and how we document allergies in medical records. The reason it's a disclosure is this is not reflecting what the committee thinks. It's my personal opinion and interpretation of the literature. So our objectives for today, I'm trying to kind of divide the talk into 2. Hopefully I'll be successful. We'll talk about drug allergies and how we evaluate patients with drug allergies. And we'll talk about some management options. And then we'll switch gears to looking at EHR and how it's involved in drug reactions and drug allergies and how it kind of complicates drug allergy evaluation and management. So the definition of drug allergies, it's an immune response to a pharmaceutical or a formulation, which is dose independent and unpredictable. Kind of self-explanatory now how drug allergies work. So we know that most drugs are low molecular weight structures, and they're so simple structures that they don't stimulate our immune system. And so we know that majority of the reactions are not drug allergy reactions, and we'll talk about that in the later slides as to what percentage of drug reactions are actually drug allergy reactions. The exception to this rule is biologics. Biologics are newer in our field, and they are larger molecules. The good thing with biologics are they are also not immune stimulating, at least most of them, because they are either humanized or partially humanized molecules. So the other aspect of drug allergy is antibiotics are overused. And we know that from data that antibiotics are the most commonly used medications prescribed in a healthcare setting. And a significant portion of that is inappropriate use of antibiotics. We see this in pediatrics, we see this in adults. And this is especially a problem for patients with certain conditions. We call it high immune active state. And some of it, of course, dealt by rheumatology here, like autoimmune conditions. We have viral infections for which they get prescribed antibiotics. And also HIV and cancer state, which are high immune active state. And when you put in a drug in it, it just predisposes to drug allergies. The other aspect to it is that we don't have good diagnostic testing for drug allergies, and hence there is overdiagnosis of drug allergies because we don't have standardized testing reagents. The only one we have at this time, which is FDA approved, is penicillin. And so other drugs, we use non-standardized testing, which limits our ability to accurately diagnose those patients. So how does the problem look? Drug hypersensitivity reaction, drug HSRs, they account for around 20% of all adverse drug reactions. So today's focus will be on hypersensitivity reactions to drugs. 80% of them are not related to drug allergies. So that's important to note. So not most of the patients you see are probably having some sort of adverse drug reactions, but not an immune-mediated reaction. So it affects around 10% of the US population that report beta-lactam allergy. It's a big problem. 32 million people in the United States have documented penicillin allergy. And every time you prescribe penicillin, approximately 2% of them result in a reaction. So drug allergy labeling has a pretty significant public health and patient safety implications because we have to use alternative broad spectrum antibiotics, which causes side effects and can contribute to resistance, bacterial resistance, and also shoots up healthcare costs. So I use my informatics skills and use some slicer dicer for our health system and looked at prevalence of drug allergy in our cohort. This is a 1-year data from, I think I had it last week. So looking at just slicing and dicing based on allergies and contraindications, you see there are like around 39,000 patients with penicillin allergy. The next most common is sulfur, and the next most common is codeine. We won't be focusing on codeine, but interestingly, there's also amoxicillin as a separate allergy from penicillin. So it shows you the way documentation happens in EHRs is kind of not that accurate. Then if you slice this penicillin further down, because keep in mind, this is allergies and contraindications, to just allergies, you get around 14,600 patients with just penicillin documented as an allergy. So that's a sizable portion of patients who have this problem. So what are the risk factors for developing drug allergies? So we know that adults are more likely to develop drug allergies just because cumulatively they've been exposed to more drugs in their lives. And it's also more common in females, and it's also self-reported more commonly in female sex. About a quarter of the patients who are in the inpatient setting report some sort of adverse drug reactions. And we know that IV drugs or drugs administered parenterally are more common to cause adverse drug reactions. And also higher doses of the same drug are more likely to predispose to drug allergies. And then we come to this interesting condition called the multiple drug allergy syndrome. We see this quite often in our clinics. These are patients who have maybe 10, 30, or even 50 drugs listed as allergies in their EHR. And some of the studies have looked at what this population could be. These are patients who have drug allergies across multiple different pharmaceutical classes, which is not typical for an immune type hypersensitivity reaction. And what they've found is patients with multiple drug allergy syndromes tend to have more of the associated diagnosis of depression, anxiety, and somatic disorders. But they're also finding some newer evidence that their histamine responses might be different, but that's a minority of the patient, but majority have something else going on rather than true multiple drug allergies. We know that concurrent viral infections and antibiotic use is a problem, and that can predispose a patient. And as we have talked before, patients who are at a high immune active state, cancer, HIV, cystic fibrosis, and co-administration of antibiotics can lead to drug allergies. So we know that up to 3 times more likely to have antibiotic allergy in cystic fibrosis patients. They get a lot of antibiotics in their lifetime. So just looking at this broad classification of adverse drug reactions, if you look at adverse drug reactions, we have on-target adverse drug reactions. These are predictable based on the pharmacological action of the drug. An example is antibiotic-associated C. diff. Then you have this off-target adverse drug reactions. We have non-immunologically mediated. Example is aminoglycosides induce acute tubular necrosis. Then you have this interesting one, which is immune receptor interaction. We'll talk a little bit about this later on, where there is direct activation of the drug through this receptor MRGPRX2, causing direct mast cell release and the symptoms. So fluoroquinolone is one of the drugs which can do that. And then what we're going to focus today is the immunologically mediated hypersensitivity reactions. And those are your antibody mediated, the IgE ones, which is penicillin-induced angioedema. And then you have the T-cell mediated one, where there is interaction with T-cell receptors, example of abacavir hypersensitivity. So when you look at mechanisms, there is not one mechanisms or few different mechanisms which can explain all of the different types of hypersensitivity reactions which happens to our patients. So we need more than one classification. The traditional one, which has been used and taught in medical school, which we still use, is the Gell and the Coombs classification. And that goes from type 1 to type 4. Type 4 is again divided into 4 different types of type 4 reactions. Not so clinically important, but to understand mechanisms that might be relevant as well. Then we have some of the newer proposed models to explain some of the drug reactions which happen without prior exposure to the drug. So I've kind of divided them into B-cell mediated, which comes from 1 to 3, and then you have the T-cell mediated from type 4 and the other 3 proposed models as well. The PI model is a pharmacological interaction. This is where the drug directly interacts with the T-cell receptor without prior exposure and can lead up to a reaction. So that model is able to explain some of the drug reactions which happen without prior sensitization. So what can we do as providers or physicians seeing these patients? History is still important for us, and we teach our fellows, students, everyone else, especially in drug allergies, it's extremely important to get a detailed history of the temporal sequence of events which have occurred. One of the problems with that is most patients, well, they wait for us, wait for the appointments. Some of them, come to us after a few years, they forget what the reaction was, they don't document. So, but for those patients who do remember, the temporal sequence of events, meaning when the drug was taken, when did the symptoms start, how long did the symptoms last, what kind of treatment was given, all of those kind of in your mind, as you talk to your patients, you're starting to think, where do I classify this patient? Is it a true hypersensitivity reaction? Is it an adverse drug reaction? Is it a known side effect of this medication? Should be running through your head. And then if you think this is immune-mediated adverse drug reaction, you start to classify it based on the classification I showed you, because that has implication as to how you will diagnose these patients and use testing to support your diagnosis. We know that cutaneous manifestations like rashes is the most common feature of drug reactions. And the characteristic of the rash sometimes helps because we think urticarial rashes are more type 1 reactions, and the maculopapular or anything beyond that could be type 4 reactions. But it's not set in stone, so we don't use that alone to classify these patients. There is also this 1-1-1 criteria we use. The criteria stands for having an adverse reaction to a drug within 1 hour of the first dose, within 1 year since the last exposure to the drug, and resolving within 1 day. This criteria helps you say that the patient is more likely to test positive on a skin testing, and this has been shown in studies. So you use this criteria to formulate your history taking from your patient, and it will help you decide, hey, this is more likely a drug hypersensitivity reaction. Also keep in mind there's fixed drug eruptions. These are eruptions which happen in a specific location on repeated exposure to the drug. So briefly on diagnosis, we'll focus more so on this. Hopefully you guys can see that. So on this side, it talks about what is the presentation. As I said, when you're taking a history, you're thinking about what kind of hypersensitivity this patient might have. So let's assume based on history, physical exam, hopefully mass tryptase levels. We don't always get this, unfortunately, during an episode, but that is very helpful during an acute episode, either in the ED or wherever else this is happening, to get an acute tryptase level if you're suspecting an anaphylactic or a systemic reaction to a drug. That helps us quite a bit when we make this diagnosis. So let's assume you have that as well, and you're suspecting a IgE-mediated reaction. And usually the timing is anywhere from 1 hour up to 6 hours. We usually say less than 2 hours, less than an hour would be a type 1 reaction. In those cases, we do use skin prick testing, and we use this as a standard. As I said, only penicillin has a standardized skin testing. As you can see here, this patient reacted to penicillin polylysine. It's a major determinant of penicillin, so clearly a positive test. We also use intradermal testing. This is similar to your PPD. You see a positive penicillin polylysine testing, clearly indicating this patient has a positive penicillin allergy. If the skin test is negative, you could always proceed with a full single dose or a graded dose challenge to rule out a drug allergy. And there are some which we don't use. It's research or limited use. It's basophil activation and serum-specific IgE. They don't have robust studies to support use of those testing at this time. Based on history, if you're suspecting a T-cell mediated reaction, you could do patch testing. Patch testing is much better now than it used to be before. We have companies where they actually make these drugs for us. We can use it in patch testing and diagnose delayed type hypersensitivity reaction. This one's showing reaction to amoxicillin and ampicillin, 10%. These are read at 48 to 96 hours. If you don't have access to patch testing, you can always do delayed intradermal reading. You do an intradermal testing like this, see the patient back in 48 hours. And then you'll have a reaction which you can use to support your diagnosis. You can also do drug challenges. It's not commonly used in type 4 reactions because the reaction is delayed. So you'll have to do multiple day kind of a challenge, or at least observe them over a period of time. Then there are limited use down here, which we don't typically use. HLA typing and pharmacogenomics are used in some types of drug reactions or predicting drug adverse reactions. So the graded challenge is a technique we use in the clinic. As I said before, this is mostly to make a diagnosis or rule out a diagnosis. So this needs to be differentiated from drug desensitization, which we do it all the time in the inpatient setting. If somebody is truly allergic, but we still want them to have the drug, it's given in a graded slow dosing over a period of a few hours. So for graded challenges, as a provider, you're almost certain that this patient does not have a drug hypersensitivity reaction. You've either come to that conclusion based on history, or you've done history and testing. And then this would be a good patient for a graded challenge. More recent literature shows that we could do a single dose challenges for most patients. We don't have to do graded challenges. It not only saves time, it's less anxious for the patient while they wait. So patient selection is extremely important, and this can be done either in the inpatient or outpatient setting. There are some contraindications which are listed there. Any end organ damage, we would not challenge those patients with the same drug. And if they tolerate the drug, we say they're not allergic, we take it off their list. So that is the distinction. Sometimes it gets confusing for some folks. Challenges are different from desensitization. Patients who have been desensitized are still allergic. They're able to temporarily tolerate the drug because we made their immune system tolerant to the drug. So we'll focus on few antibiotics. We know that beta-lactams is the most commonly used antibiotic. We know that greater than 90% of patients with penicillin, history of penicillin allergy are not allergic, and I think that's close to 95% plus. We also know that 10%, you lose 10% of your allergy every year. So around 10 years is a good time to get reevaluated for your penicillin allergy. There is very minimal cross-reactivity between penicillin and cephalosporin. And we have done some work here at VCU as well. Perioperatively, we looked at cross-reactivity between penicillin, cephalosporins, and which could be a safer alternatives for perioperative antibiotic use. And we know that there's no cross-reactivity between penicillin and monobactams. And we'll talk a little more on the beta-lactam cross-reactivity. So when you see a patient with penicillin or beta-lactam allergy, there are a number of tools we can use. There is PenFast, there is this one, risk stratification. This would apply to a non-allergist. I think there are some sections here which you could use in your day-to-day practice. Like, for example, the patient has GI upset, headaches, and yeast infection, or a family history. We see this commonly as well, family history of penicillin allergy, and they automatically label themselves as being penicillin allergic. That's a good one to delabel. And anyone can do it, any provider. They are very low risk for actually having a reaction. Same thing goes with these non-urticarial rashes or rashes which happened greater than 10 years ago. You could go with a graded challenge. I wouldn't recommend two-step. You could go with a single dose challenge, or you could, of course, refer out to allergy. And I think the next three would be where you would probably refer out to an allergist for further evaluation. If they had a potential IgE-mediated reaction, anaphylaxis, because we have the tools to figure out if the patient is still allergic or not. And some of them we try to steer clear, although there's new data coming in about how we can test for these severe cutaneous adverse drug reactions like DRESS and Stevens-Johnson's. So the penicillin testing is pretty straightforward. It's standardized. This is PREPEN. It's FDA approved for penicillin testing. PREPEN positivity indicates anaphylaxis to penicillin. So some of the times we just use PREPEN and not the minor determinants, which are these, including what we use in the clinic is PENG. The minor determinants are not available in the United States. It's not FDA approved. They did try twice. I guess they weren't successful. We also include ampicillin and amoxicillin to rule out side chain reactors. These are rare, but they could be patients you might miss out if you don't include ampicillin and amoxicillin. And that's why the final challenge we do if they're negative is with an amoxicillin. So we can rule out all of these different things. Concentrations for testing is listed there just for anybody who's interested. And this is what our protocol looks like. We go from starting from prick testing for the patient, go to, if it's negative, go to intradermal testing. There's PREPEN and the PENG in different concentrations. So if a patient is negative on penicillin testing, their chances, it's a broad range, 0 to 4%. So there is still a small chance of reacting, and that's why we follow that with an amoxicillin challenge. Switching gears to cephalosporins. Cephalosporins are allergy is less prevalent. It's 1.3, 1.7%. And cephalexin is the most commonly reported drug because it's most commonly used. The cross-reactivity in cephalosporin is based on side chains. And if you guys can see that portion, the R1 side chain, which is here, and it's divided into 6 groups. And the cross-reactivity is mostly based on the R1 side chain, not to the beta-lactam ring itself. So switching gears to beta-lactam reactivity, since we know the cross-reactivity between cephalosporins and penicillins are very low, and also that the side chain is what matters, not the beta-lactam. How do we approach patients? And these are just some common scenarios I put in there. So you have the beta-lactam ring. The cephalosporin has the beta-lactam ring, but we care more about the R1 side chain for these patients. And of course, this one shows that penicillins has between penicillin and cephalosporins, this is even less. This is a 2017 study. The more recent practice parameters talks about less than 1% cross-reactivity between penicillins and cephalosporins. And we'll look at a couple of scenarios how you can decide what you want to do with your patients as we go along. And there is minimal cross-reactivity between carbapenems. So the recommendation is to just use carbapenems for penicillin allergy. And there's no cross-reactivity to monobactams like aztreonam, and you should be okay to use. If this is not enough, you want more complex, there are papers and there are much complex systems you could use. And I think I like it, even though it looks complex. This basically talks about what can be used if somebody's allergic. I think looking at just the white boxes, there's no shared class-specific ring. You can see that some of the penicillins like these cross-react with some of these cephalosporins, and we'll talk about how you can navigate that when you have a patient like that. But this is also helpful to looking at this, having it on your phone or somewhere where you could reference out how you look at cross-reactivity between penicillins and cephalosporins. So I just have a few scenarios. So the recommendation is you have an unverified. Unverified is they have not been tested before, and it's reported non-anaphylactic penicillin reactors. So general recommendation for drug allergies is classify them into verified and non-verified and anaphylactic and non-anaphylactic. Of course, the unverified non-anaphylactic are the low risk ones. And in a case like that, you could use any cephalosporin without testing. And if you had an unverified anaphylactic reaction, you can use a non-cross-reactive. You reference out to that table, non-cross-reactive cephalosporin without testing. And you have a verified non-anaphylactic reactor to penicillin, and you can pick a non-cross-reactive cephalosporin and do a drug challenge. And this can be done inpatient easily. It's a single dose challenge. You wait a couple of hours after the dose and everything is good. You clear them off an allergy. If there's a verified, the other way, cephalosporin allergies are extremely rare. It's not as common as at least reported penicillin allergy. So, but in case you do have a patient who has reacted to cephalosporin, then you have to do skin testing and a challenge to the penicillin. So the other way around, again, unverified non-anaphylactic reaction to cephalosporin, you can use penicillin without testing or challenge. We know that the beta-lactam cross-reactivity is very, very low in these patients. Going to the next most common antibiotic, sulfonamides. I just wanted to point out, because this is, again, we see this commonly in our patients. There's no increased risk in the general population between sulfa antibiotics and non-antibiotic sulfa. We see this commonly put into EHRs in the allergy section. Somebody says sulfa. They don't verify what sulfa it is. They think it's sulfa, and then EHRs are also not that smart. When you say sulfa, it kind of pulls every sulfa, which includes non-sulfa antibiotics as well. And some of the examples of non-sulfa antibiotics includes the sulfonylureas, the glipizide. I don't use many of those. The loop diuretics, the COX-2 inhibitors like celecoxib. The newest recommendation for sulfonamides testing and evaluation is that we don't have standardized testing for sulfurs. So if the reaction has been over 5 years, you could do a single dose challenge. If the reaction is less than 5 years, I know it's pretty vague in that sense, but sulfonamide reactions, skin testing is not that accurate. So less than 5 years, you would do a two-step challenge. So moving on to fluoroquinolones, we'll talk a little bit about how unique fluoroquinolones are, because they can stimulate the MRGPRX2 pathway and stimulate mast cells. And so very similar to vancomycin, Some of you might have seen the Redmond syndrome with vancomycin. It does go through the same pathway. And the cross-reactivity in fluoroquinolones is not known. We don't know for sure how cross-reactive all of the different fluoroquinolones are. So the proposed approach is very similar to sulfonamides. Reactions greater than 5 is one-step challenge, and reaction less than 5 years, you use an alternative fluoroquinolones because there is assumption that they don't cross-react as much. So what is this MRGPRX2 and drug reaction? I think this would be helpful to know. This is present on mast cells, and some of these drugs can directly stimulate. You have NMDA, fluoroquinolones, vancomycin, opioids, and some of the other rarer ones can actually stimulate this receptor to cause mast cell degranulation and the symptoms. The interesting thing about this is the IgE-mediated reactions also degranulate mast cells. So they have mast cell degranulation is the final outcome of both. And this study looked at what are the differentiating features between, hey, how do I call this a IgE-mediated process versus a direct mast cell releaser? And there are some points here which talk about that for IgE, you need very low concentration of the drug, meaning that for a patient with vancomycin-induced Redmond syndrome, you could reuse the drug at a slower rate or maybe a lower concentration. And for the MRGPRX2, you don't need prior sensitization. No prior exposure is required. That's also a clue. For most IgE reactions, we do need prior exposure to the drug. And there are others, you can look through them. But the idea is that you want to try to identify, is this a IgE versus MRGPRX2 pathway? So you could reuse the drug if it is the MRGPRX2 pathway. So I think this might be the last one for macrolides. The incidence of an IgE-mediated anaphylactic reaction is extremely low. We can't use skin prick testing. We don't have standardized testing, so we recommend a straight challenge. So switching gears to challenges we face in drug allergy evaluation in the current settings. So one of the things which stands out is specialty services. We know that, I guess VCU Health is lucky. We have an allergy division and providers. A lot of big health systems don't. And so most of their inpatient don't have allergy services to navigate through drug allergies. So they end up using alternative drugs and broad spectrum antibiotics. There is also not enough allergists around the country. I think this was in one of the meetings years ago, we were talking about how to delabel patients with penicillin allergy. There's so many out there. And allergists in private practices, some of the allergists in private practices do drug allergy testing, but most don't. It has to do with reimbursement and also being careful with risk in terms of reactions to patients because they're not attached to a hospital system. We have other limitations, including trained personnel and retaining them, like nursing, to do our drug testing and challenges because those are specialized testings and they need to be trained for a period of time. And of course, there's space limitation as to how many you can test per day. Given the number of patients being labeled as allergic to the number of testing spaces we have, I think it's a losing situation in a way because we don't have enough space to do testing. And finally, the cost of drug allergy testing is pretty low. We can't get reimbursed for the actual drug itself. We are able to do this in big health academic centers, but in smaller private practices, the drug itself cannot get reimbursed. At least we don't have codes for it. And we'll talk about some of the proposed solutions, how we could do that. So these are some of the proposed solutions based on some literature review, like prioritizing having allergy specialty services, especially for inpatient, and training and retaining of your staff. Antibiotic stewardship programs, which can be linked to drug delabeling programs. They call it in different ways. This is a nice study from 22. This one academic center looked at how they would approach drug antibiotic delabeling programs. They would either go through high-risk antibiotic targets, like look at what are the most common antibiotics which are a problem, or look at high-risk population, which is perioperative, prenatal, or the other immunocompromised and others. So drug labeling can be integrated into antibiotic stewardship programs and can be an effective way to deal with drug allergy problems. And also setting up drug allergy centers. There are few centers across the country. They do a really good job because you can pool your resources into one center for testing and taking care of these patients. And finally, legislation or having a presence at AMA for some of these testing reimbursements, because right now we don't have codes for some of those drugs. So maybe something to look into as well. So switching gears, I'll try to make this fast. The next focus is allergy documentation in the electronic health records. So this was a work group report. I was part of this work group report. I would encourage, for those of you who are interested, to read it. It's really nice as to it outlines the problems, the proposed solutions, and this came out in 2022. The initial one was it started off with a survey to the committee members as to what type of allergies can be documented in an EHR. And keep in mind, there was a sample size of 23, but they came from across the country from different EHRs. And as you can see, we can document a lot of different things in the EHR, medication allergies to patient preferences to environmental intolerances. So there are a lot of things go into that small section of allergy. So we know that over the last decade, most health systems and most practices have switched over to electronic health records. And this has not only made our way to care for our patients easier, but also has some issues with allergy documentation and how it plays out. There are also no specific guidelines as to how we should be documenting allergies in an EHR. I don't believe I've seen one. This probably is one of them. We kind of suggested what we should be doing in terms of documentation, but nobody gets a training which tells you how exactly to document an allergy. And almost every provider and other have access to edit and document drug allergies. So I call it's just a dump ground where you can put literally anything and everything. So some of the challenges we face with EHR and documentation is the data quality. We know that EHR is not intuitive for documentation. Either there are too many things to choose from or too little choices. We also know that the most commonly picked reaction is actually a rash at 38%, and the next frequent is unknown at 26%. This was from one of the academic center. And allergies can be documented by providers and non-providers. So there are a lot of hands in a patient chart as to who's documenting this, and a majority of them don't have formal training or knowledge of drug hypersensitivity reaction. So there's also inaccuracies in the EHR itself. Like if you put in, not all EHRs do it, but if you put in iodine or shellfish allergy, it would automatically flag contrast reactions, which I think they've tried to take it out for most. By the way, that's not an issue. Shellfish and contrast is not an issue, two different things. And also interoperability between EHRs, even between the same EHR, like Epic, between Epic here to UVA, for example, they might not talk the same language in a way. So this is an example of one of my patients I recently saw. As you can see, this patient had probably 10 or 15 different allergies documented. And I just want to point out to a few ways this was documented. The shellfish, it says angioedema, which should be an allergy process. So it says intolerance. And also here, it says reaction type, which was a free text. It says allergy, but if you look at what was selected, it's an intolerance here. And metronidazole, which says, I don't know, and it says intolerance. The proposal is that you should flag I don't know so that the next provider can evaluate that, or an allergist. So we can really figure out what does it mean. I don't know, either I forgot, it's been a while, or somebody told me. So those would be helpful to get flagged, just showing you the inaccuracies in way we could document allergies. This is a study looking at who documents allergy in the EHR. This is from one major academic center. and majority is by non-allergist physicians, of course. And then we have nurse practitioners, PAs, and we also have a small bucket with others, social workers, physical therapists, and allergists only document 0.2% of allergies in at least in this study. So some of the proposed solutions, one of the things we've been struggling with is allergies and contraindication is how it's listed in EPIC right now. That's the one on the left side where you click to add allergies or edit your allergies. Is that even the right title? Because it's kind of, it doesn't encompass everything we put in there. So there's been suggestion for alternatives like alerts and warnings and intolerances. We've been talking about this in the committee about how we need to make some changes to the title. I think step one is change the title to include all of the different things we put into that section. Because allergies also include food and drugs and chemicals and contact reactions. And we know that allergies are just a minor portion of adverse drug reactions, so it shouldn't be the focus. How can we make the allergy data better in the EHR? Data quality, we can focus on education where everyone gets trained with the allergy-specific modules. And there should be some emphasis on terminologies. We'll talk about terminology in the next few slides. There should be documentation examples so they can know exactly how to document, and emphasis on avoiding free texting as much as possible. You might have to use it, of course, because some of them don't make sense or you don't have the knowledge to make that decision. There is also talk about doing quick pick lists for commonly used medications and also reactions. We can do intuitive building in the EHRs, and there is one of the slides I can show you one of the examples as to how we can do that. And documenting personals, there's some talk about restricting on who can touch the allergy section of the EHR. And if you're unsure, flag it for the providers. And of course, interoperability, we're talking about legislation having uniform codes across different EHRs so they can talk back and forth. And I think one of the things I didn't point out is you might delabel a patient here. The pharmacy might have a different system. They might not talk. They still have that patient as being allergic to penicillin, bounces back to the patient saying, hey, you're still allergic. They come back to the clinic 5 years later, say, I'm still allergic. And then it's a new provider. So the crosstalk between different systems is becoming more important in this day and age. So this is one of the models proposed how you could document allergies in an EHR. It's kind of a flow sheet. You start with adverse drug reaction to a drug, and it starts giving you these choices as you click, click, click. This is probably a better way to document your allergies for a non-allergist. And this will probably be one of the ways. And I know not all systems can do it. And we have tried to talk with Epic in the past, and I think it's work in progress as to whether they're interested in this kind of a process. In the meanwhile, we can empower patients. There is this app which was designed at Mass General where patients maintain their own list, where you can put drugs and food allergies and then take it to your providers. So some of the terminologies which are important to understand is adverse drug reaction is an umbrella term that includes all unintended effects of a drug. Then we have intolerances, which are basically drugs not tolerated by the individual. And then we have drug allergies or hypersensitivity reactions. These are immune-mediated reactions. And contraindications, drugs that should not be used due to harm. And unknown is the basket where you put unspecified reactions. So this is an example of what we could do while we work on fine-tuning the EHRs and talk about legislations and interoperability and all of that, is an example of how to document. I know it's going to take probably extra couple of minutes to do this for a new patient, but I don't believe drug allergies are that common. But you see a lot of patients in your clinic, but each time they come to you, they're not asking or saying that had a drug reaction. So documenting it this way, date noted, free texting, what happened would give a lot of information to either the allergist or whoever else is evaluating the risk of this patient based on the risk stratification we talked about, at least 4 penicillins. And the other one is, this is for penicillin antibiotic. This is unknown penicillin, and what you could put in there, it says that unknown childhood reaction. And that would immediately make me, if I'd seen this patient, to take that off the list or do a quick drug challenge. So finally, take-home messages, 3 simple things, hopefully you can take out of this talk, is that drug allergies only account for a minority of the reactions. Majority is adverse drug reactions of other sorts. The documentation in EHR is flawed. It has too many factors, which includes the way the system is designed, personals who are making the edits, and also crosstalk between EHR. And lastly, the most important, if you see a patient is tolerating a drug on a long-term basis, no reactions, please take that off the list and pat yourself for delabeling a patient. Thank you.
Thank you so much. We can start with some questions here from the audience.
It's less of a question. Well, that was a great talk, but there seems like there's a lot of opportunity to get you help doing this and get the system help doing this from an educational standpoint, having learners interested in learning more. I know Becky mentioned that people are out, they're interested in allergy, but there's not a lot of projects going on. Get a learner involved in making a module that can then be disseminated to the hospital system about drug allergy.
Absolutely.
They learn and then we learn. And then using the EHR system to, pull data and then create a project on that to help delabel some of these patients.
I agree. I think there's a lot of scope for small projects with this. Yeah.
Again, not a question, but a comment. I think one of the things that many of the physicians, myself included, is that when we are seeing patients in our clinic, we use the available template, and one of them is allergies, and we just skim through. We don't even do much of a focus on to ask if that is what it is and stuff. And we only focus on it if it is pertinent to what we are carrying.
Right.
So I think one of the things, at least my takeaway, is probably to look at them a little bit more, because I think among providers, if more are in tune with looking at it and delabeling them, as you had mentioned, I think it will clean up some of our patient charts, because many of them are seen by many of the providers here as an outpatient.
Absolutely. I think as I said, there are more people labeling the patients than there are people who are delabeling them. So, yeah.
Other comments? Right. Well, feel free to come up if you guys have any other questions. Thank you so much. We appreciate your time.